Absolutely. There's no setting in medicine where you'll not see patients with psychiatric issues, and good to represent psychiatry here. So we have heard so far that Wilson disease can present with really anything. I mean, liver problems, neurologic problems. In a smaller subset of patients, these patients can just present with psychiatric issues. And it's really challenging because right around the time that people start manifesting symptoms of Wilson's disease around the same time where a lot of these psychiatric issues manifest, right? So if somebody suddenly presents with psychiatric issues at the age of 50, we're gonna scan their brain, we're gonna do a thorough medical workup, but somebody is not acting right, they're having symptoms of mania, psychosis, even depression when they're late adolescence, early adulthood. That's typically the time where these illnesses start. And it's really imperative as psychiatrists that we look for any signs and do a Wilson's disease workup, especially if the patients do have signs of hepatic impairment or any neurological symptoms. So the issue with psychiatric symptoms, unlike some of the hepatic stuff and the neurologic stuff you've heard, we don't really have a lot of objective data. You can't look at a brain scan, you can't look at like labs and figure out what's going on. It's a lot of subjective symptoms, and that's why you're going to see in the literature there's going to be a huge spread of how common these issues are in patients with Wilson's disease, and depending on the scales they've used, depending on who's doing those evaluations. But it's fair to say, I mean, it's such a significant illness that's bound to have impact on somebody's way of coping, and it's common for people to have mental health symptoms throughout the course of their disease. Depression obviously is the most common psychiatric symptom you're going to see in these patients, anywhere from 20 to 60%. There's actually data that came out from the Yale group with the registry that they have about 37% of people, I think the sample size was 70-odd patients, did have lifetime depressive symptoms. The mechanism is not very clear. We have heard about that the copper gets deposited in the brain, especially in areas where there's a lot of dopaminergic neurons, the basal ganglia region, and can lead to a multitude of psychiatric presentations. But also, as I said, I mean, the toll that the illness takes on a patient, I mean, it may limit their social functioning. It does put a lot of pressure on their ways of coping. So it's hard to kind of tease apart the mechanism of these psychiatric symptoms entirely due to the deposition of copper in the brain versus the impact that the illness has. And, again, it's, even though psychiatry and neurology are different fields, but you can't really separate brain and the mind, right? So if anything's affecting the brain, it can cause symptoms of the mind. So what's the first thing we do when a patient comes in with some psychiatric symptoms? It's important to interview the patient, get information from friends and family, what's been the trajectory of their symptoms, because mental illness is relatively common in the general population. It may certainly predate Wilson's, or maybe a completely separate illness in addition to the Wilson disease. A few things that's important for patients and people who may not be in psychiatry. There are a multitude of rating scales that are very well validated in patients with medical issues, and that's something we do advocate. In the general medical settings, there are some reliable scales that we use to screen and monitor treatment for patients with psychiatric issues. The PHQ-9 patient health questionnaire, very commonly used to evaluate for depressive symptoms. The GAD-7 generalized anxiety disorder 7-item scale for anxiety disorders, and mood disorder questionnaire, rapid mood screener to evaluate for bipolar disorder. So these are scales that are commonly used in the medical settings. So talking about the most prevalent psychiatric symptom we see is major depressive disorder, which is a constellation of signs and symptoms. Obviously anybody can have depression, right? I mean, we all go through things, but it constitutes a disorder when it comes with a multitude of other symptoms that come with it. So the important thing for patients and clinicians is to look for these specific signs, because unfortunately, in our diagnostic algorithm, all of these signs are kind of weighted the same, but we know, things like, let's see if I can get some pointer here, like fatigue, sleep issues, weight, appetite issues, that can happen in any medical issue. So things that are very specific to the diagnosis of major depressive disorder is what we call anhedonia, or reduced pleasure in things. If somebody is not enjoying things that they did, that's a very specific sign. feelings of worthlessness, guilt, and typically you see a diurnal pattern where the symptoms are much worse in the morning. Talking about the other psychiatric disorder we can see in this population is bipolar disorder. And again, as I said, there's a huge variable depending on the study you look at. And typically when somebody presents bipolar disorder, you're going to see periods of depression, like we kind of talked about that in the previous slide, but also periods of mania or hypomania, which is typically hallmarked by increased energy, right? So the person has a deviation from their normal sense of personality. They have lots of energy. They may not be sleeping. There's elevation of mood, can be irritability. People may have racing thoughts. They're more talkative than their baseline self, distractibility, and may engage in risky activities. That is, you know, if a patient is having all these signs, there's an indication that they may be having a manic or a hypomanic episode. But outside of that, I mean, you know, as Dr. Rudnick talked about kind of the gray area, there's a lot of gray area here, right? So there may be people who kind of on the spectrum who don't meet a full criteria of this, especially the Wilson disease patients I've seen. They may have a lot of mood instability, personality change, irritability, all those things are described. And again, it's still, you know, we don't have good data how much of that correlates with the copper deposition in the brain versus somebody's way of coping and their, you know, we all have a threshold of resilience, right? When we're faced with a lot of issues, we can, you know, have a lot of irritability. There may be changes in how we relate to people. So it's really important to understand that, you know, medications is only going to be one part of our treatment, and psychotherapy and counseling can be extremely helpful. Now, talking about psychosis, which is really a deviation from, you know, reality, right? It can present in multiple ways. People can have delusional thinking, hallucinations, hearing voices, seeing things that, you know, are not there, may have a disordered way of thinking and behaving. And this is typically rare, but it certainly can happen. And, you know, these are the kind of cases that are, you know, people have done case reports and stuff. Some of these patients end up being in psychiatric settings, you know, don't respond to treatment, get loaded on different medications. And the problem is we're going to see, you know, with the basal ganglia being affected and some of the medications we use in treating psychosis can exacerbate those Parkinsonian features, those rigidity, tremors. And it's really important thing to keep in mind. If the patient is not responding to conventional treatment, you may want to look at, you know, medical basis for their disease. And the problem is patients who maybe experience psychosis, they, you know, one of the hallmarks of psychosis is people don't really have great insight and judgment, and that may limit their medical workup. You know, there's countless amount of people that I see on our consult service that they have, you know, pretty significant medical condition, and because of the underlying psychosis, they don't believe they have it, right? So there's only as much, you know, forced treatment you can do in terms of holding them down and you know, doing the diagnosis, doing the treatment. So it's really important to recognize this and use medications for the most part, because it can limit you know, patients' insight and judgment, and refusal of care certainly can lead to deterioration of their illness. So suicidality, this is thankfully less common, but it's one of the most you know, important things to look out for. Can be extremely stressful for not only the patient and their family. And you know, again, we don't really have great data from, you know, Wilson's disease, but again, you know, it's a rare illness, and you know, suicidality is thankfully relatively rare in this population. But you know, if there's any psychiatric illness, it's important, and that's part of the standard of care for any psychiatrist. As part of their mental health evaluation is to do a safety assessment. And patients who do have these thoughts, it's important to assess their access to means. I mean, especially, you know, where we are. I mean, you know, access to guns is very easy to get, and the access to lethal means, the method, onset, frequency. It's really important to kind of get those data points and really try to figure out a plan where you can mitigate some of these acute risk factors. And if somebody is going through an acute suicide crisis, they're having an active plan and intent, they need to be psychiatrically hospitalized, or at least be taken to the emergency room. And again, there's a lot of variability in states. I mean, I know there's a huge international contingent here as well, but in the state of North Carolina, at least the county that I'm in, any family member can go to the magistrate and they can issue an order for the police to bring the patient to the emergency room if there's a concern for their imminent safety. So it's really important when the patient presents, you look for modifiable risk factors and come up with a plan, right? I mean, in the past, people just used to just sign like a safety contract. You're not going to kill yourself. All right, let's just document that. Those things don't work, right? So you really want to come up with a plan. What are the triggers? Like, who are the people that they can call if they're going through a crisis? Because when people are going through a really stressful state, I mean, we all have experienced that, right? When our emotions are really high, we can't think rationally. And sometimes kind of having that written plan in front of them, who they can call, what they can do, what are the things that works in terms of their ways of coping with stress and anxiety can be extremely helpful. So, it's kind of the million-dollar question, right? What kind of came first, or the psychiatric symptoms are purely due to Wilson's disease, or it's kind of a separate disease entity in addition to the Wilson's disease. One of the ways to kind of look at the trajectory of the psychiatric symptoms only started with the neurological and the liver symptoms, and if there's an abrupt onset and things that kind of don't make sense from our diagnostic algorithms, these are all signs that it's due to the Wilson's disease. And some of these things may just get better with the treatment that's specific to Wilson's disease that my hepatology colleagues have already mentioned. So removal of copper deposition can help with a third of these patients, but there's a significant role of psychiatric medications, especially in severe cases. If you're kind of mild to moderate depression and anxiety, I'm a huge believer of psychotherapy that can be extremely helpful. And the other important thing to know is if patients having a lot of psychiatric issues, a lot of psychiatric hospitals, in this country, and I imagine the same in other countries as well, are not equipped to handle a lot of medical complexity. So typically these patients are treated in the medical settings with psychiatry consultation. And so when somebody is presenting with depression, again, the goal is complete remission. We kind of take a stepwise approach, stopping medications that can lower mood, definitely address if there's substance misuse, sleep hygiene, regular exercise. Those are all things that is recommended. Behavioral activation is when somebody's like down and they're like nothing is going well, literally just getting them out of that state, going out, like, doing things that helps boost your ego and that helps people feel better. So there's a huge role of doing these things in addition to psychotherapy, especially in mild to moderate cases. When somebody's depression is so severe, they're not getting out of bed, they're losing pleasure in activities, medications are typically used, and all medications are, for the most part, that we use are equally efficacious. Really depends on the right medication for the right patient in terms of the side effect profile. And as was already mentioned, like some of these treatments that we use for bipolar and psychosis, the antipsychotic medications that can contribute and worsen some of the movement issues. So you have to be very judicious using these medications and typically using medications that don't increase that side effect burden. One of the most common mood stabilizers we use is lithium. It has just renal clearance. It has nothing to do with your liver. So that's a medication that would be used most commonly in people with bipolar disorder. So in summary, psychiatric manifestations can represent a significant part of clinical presentation of Wilson's disease. It can happen during any point of time during their illness. And the first step in the evaluation management is going to a mental health professional, taking the history of the patient, getting collateral information from family, trying to figure out what's been the course of their illness. Early detection can certainly improve outcomes, and as I said, as the psychiatric symptoms the burden of psychiatric symptoms can limit, the patient's adherence, right? If somebody's so depressed they don't want to get out of bed, they're probably not going to see their doctor, not be compliant with their treatment. So it's really important for aggressive treatment when patients are presenting with psychiatric symptoms. And selecting medications that don't add to the neurological burden, and that's the case for a savvy psychopharmacologist, kind of choosing medications that don't worsen some of the movement side effects. And again, the goal is complete recovery. And that's all I have.